Good morning. Incidental diagnosis of a pancreatic adenocarcinoma in a woman affected by gestational diabetes mellitus. Case report and literature review. The global incidence of pancreatic cancer is rare, 4 cases per 100,000 women. Only 3 to 4% of cases affect females of reproductive age. The risk factors are obesity, heavy smoking, alcohol intake, history of diabetes, chronic pancreatitis, chronic cirrhosis, previous cholecystectomy, and genetic predisposition. It postulated a connection between GDM and pancreatic cancer. In more detail, it has been postulated that women with a history of gestational diabetes mellitus show a 7-fold increase in the risk of pancreatic cancer over the course of their lives. We report the first pancreatic adenocarcinoma incidentally suspected in an asymptomatic woman affected by gestational diabetes mellitus undergoing a fetal growth scan. Our patient presented the following characteristics: 37 years old Caucasian woman, overweight, no previous medical history, assuming no medication or problems associated with tobacco or alcohol, no family history of cancer, but both parents had been affected by type 2 diabetes mellitus. Previous pregnancy complicated by fetal macrosomia. The woman came to our fetal medicine unit to receive a fetal growth scan due to a recent diagnosis of GDM. During the scan, a complex mass on the left upper quadrant of the maternal abdomen was incidentally found. Then, an urgent magnetic resonance imaging was requested. On T2 weighted images, a complex cystic lesion arising from the tail of the pancreas was clearly depicted, and T1 weighted images demonstrated the presence of 2 components, cystic and mucinous, within the lesion. A multidisciplinary team evaluated the case and counseled the woman and her family. Both a caesarean section and a distal pancreatectomy plus a splenectomy were successfully performed at 34 weeks of gestation after completing a single course of corticosteroids. A healthy female of 2,400 grams was delivered. No need for neonatal intensive care unit admission. The entire surgical procedure lasted 4 hours. Blood loss of 1,200 milliliters. 2 post-operative Jackson Pratt drainages were placed respectively on the left and the right side of the abdomen for 10 days after surgery. The pathology study revealed the presence of a poorly differentiated adenocarcinoma of the pancreatic tail with an unaffected spleen. Postpartum computed tomography showed no metastatic disease. The patient was discharged on the 15th day after surgery. 1 month after discharge, she started number 6 cycles of chemotherapy based on gemcitabine. At that time, she was advised to discontinue breastfeeding. 8 months later, the patient and her child are both alive and well. We conducted a systematic review that let us find 30 studies describing 31 cases. The majority of women were symptomatic at presentation. Pain, in particular epigastric pain, has been the more reported symptom, associated with vomiting and jaundice. Only 2 patients were asymptomatic at presentation, but both resulted to be affected by a cystadenocarcinoma at pathology examination. On the contrary, symptomatic women were affected by a pancreatic adenocarcinoma in almost totality of cases. Abdominal ultrasound, computed tomography, and dosage of carbohydrate-associated antigen 19.9 have been the most commonly performed examination during the diagnostic process, but magnetic resonance imaging (MRI), due to its sensitivity and specificity in the diagnosis of pancreatic cancer, has been progressively more requested in the presence of a suspected pancreatic mass. The majority of cases resulted to be unresectable already at presentation. Only 32% of women did benefit of a surgical procedure. 4 out of 10 in the antenatal period of time, 6 out of 10 after delivery. Surgery was performed during pregnancy for cases diagnosed during the first or early second trimester of pregnancy. The most common chemotherapeutic agent used as adjuvant treatment was gemcitabine. 2 patients received treatment as well during pregnancy, and no neonatal repercussions have been documented after birth. The histological result among the specified cases has been a pancreatic adenocarcinoma for more than 80% of cases. 3 cases were cystadenocarcinomas. 20 maternal deaths had been reported already at the time of publication. Cystadenocarcinomas had a more favorable outcome in comparison to adenocarcinomas in terms of maternal deaths, reported at the case publication time. From an obstetric point of view, 6 pregnancies were complicated by an hypertensive disorder of pregnancy. 3 of these were as well suspected to be complicated by an HELLP syndrome, due to the presence of persistent epigastric pain. 2 women were diagnosed with gestational diabetes mellitus, but both at pathology examination resulted to be affected by a cystadenocarcinoma. 8 caesarean sections have been performed to manage the disease or due to deterioration of maternal conditions. Nearly 70% of women had a preterm delivery, more than half to be able to manage the disease. Diabetes is a well-known risk factor for pancreatic cancer. With this regard, a prospective cohort study did demonstrate that women with a history of GDM have a 7.1 relative risk to develop a pancreatic cancer during their lives. The postulated explanation has been a contribution of hyperglycemia and hyperinsulinemia. Hyperglycemia increases the generation of reactive oxygen species, which can damage the DNA if antioxidant mechanisms are overwhelmed, and this could lead to the loss of function in crucial proteins involved in tumor suppression. Hyperinsulinemia, typical of both type 2 diabetes mellitus and gestational diabetes mellitus, increases cell growth in pancreatic cancer cell lines. Our case report described the first case of pancreatic adenocarcinoma incidentally suspected in an asymptomatic woman affected by gestational diabetes mellitus, undergoing a fetal growth scan at 29 weeks of gestation. This is the 3rd case of pancreatic cancer diagnosed during pregnancy in a woman affected by GDM. Interestingly, our patient was an overweight woman with a strong family history for type 2 diabetes mellitus who had previously delivered a macrosomic newborn. A potential role of both hyperglycemia and hyperinsulinemia could be postulated in the occurrence of this case of pancreatic cancer diagnosed at an early stage and successfully managed. In cases of women affected by gestational diabetes mellitus, given the correlation between this condition and the occurrence of pancreatic cancer, the routine fetal growth scan should be leveraged not only to ensure fetal well-being, but to assess maternal condition. For suspected maternal abdominal masses, an urgent magnetic resonance imaging and carbohydrate-associated antigen 19.9 should be requested. Thank you for listening.